Corneal dystrophies can be regarded as any congenital abnormalities that can lead to any abnormality at the level of corneal epithelium, even sometimes the Bowman's membrane, the stromal layer, the internal limiting membrane, or the Descemet's membrane can also be involved due to these genetic mutations that occur. So when we go into the detailing of these genetic mutations that are occurring and then obviously resulting in the corneal dystrophies, we come to know that these mutations can be autosomal recessive in their nature, they can be autosomal dominant in their nature, and these are the different kinds of genetic mutations leading to these kind of corneal dystrophies in a patient. While you are running in an outpatient department, you would come across these different patients that would come up to you with the haziness in their cornea. The main clinical feature that they would be complaining of is the blurring of their vision. So when you would get into investigating these patients, you would come to know after having done the baseline investigations in these patients for any other systemic abnormality if they are suffering from, and you have a normal studies that are related to that patient. He or she is not suffering from any sort of hypercholesterolemia, hyperlipidemia, any sort of systemic infections. For example, it can be even the amyloidosis, even the diabetic patients can present with corneal haziness. So all of these long-standing conditions can sometimes present to you with a corneal haziness, a generalized corneal haziness that is noted even in these kind of patients. So there would be quite a differential diagnosis, a list of differential diagnoses that you're going to have, and you're going to just jot that down. On top of that list would be the corneal degenerative processes, then would be the corneal dystrophies. Then you may have systemic infections and systemic manifestations as well in these patients. So the baselines and to have a complete history from the patient is again very important. Starting off from the age of the individual, then obviously you would move on to any history of trauma or ocular pathologies or any history of ocular surgeries that the patient had undergone. So you would be basically noting down all of these features, and after that you're going to see what are the positive findings in the history. What are the positive findings in the physical examination of the patient, and that can lead to the definitive diagnosis of corneal dystrophies in these patients. So over here, first of all, when we look at these patients of corneal dystrophies, we may know that these dystrophies can affect the epithelium as well. We all are well versed with the fact that the corneal epithelium is a stratified squamous kind of epithelium that is basically lying on a tight layer of columnar cells with tight junctions, which is again resting upon the Bowman's membrane. After that, we have a stromal layer, and sometimes these dystrophies can even involve the epithelial layer, they can involve the stromal layer, and even they can move up to the Descemet's membrane, which is quite a tough membrane, and that can be sometimes involved and be a part and parcel of this kind of a pathology. So again, it's very important to examine the patient in detail over here. You would be noticing the peculiar features, what kind of the corneal haziness is noted down. For instance, if it is just an epithelial kind of a corneal dystrophy, that is the most common type of corneal dystrophy, it is usually a map-like appearance of the haziness that is noted down in these individuals, as you would be looking, and we'd be focusing on the different clinical presentations over here in this lecture. So as you can see over here, these are the different patterns that you can observe on direct illumination, and on examining these patients in detail, you would note down that there is this lattice work haziness that is noted down at the corneal epithelial level in this patient. Once you have diagnosed this individual to be suffering from corneal dystrophy, what are the next steps that you're going to take for this individual? Obviously, you're going to look for the fact whether he or she is suffering from any long-standing infections. For example, it can be even the keratitis that is predisposing and giving off this haziness to the cornea. So you would be completely investigating the patient for any kind of systemic illnesses. And one of the most key factors over here is the age of the individual. So if it is a young patient, if it is an infant, the most common thing that would come up to your mind is the corneal dystrophy, because it is the congenital abnormality that we're going to talk about relating to the epithelial cells. So it is the age of the individual sometimes that is the key factor, and that is pointing out towards the corneal dystrophy in these individuals. So usually these are the inherited disorders. The cells have inborn defects. There are the inborn mutations in the cells of these individuals. And then the development of the corneal haze is quite normal in the eyes. It's usually manifesting occasionally at birth. That is, usual manifestation is the first and the second decade of life. Below 20 years of age is the most common presentation in the outpatient departments. And then they are not associated with any other systemic disease. The condition is usually bilateral, that is, it is affecting both of the eyes rather than a unilateral condition. If it's a trauma, if there is a history of trauma, that would be usually a unilateral condition affecting only the side of trauma. So over here, the patient would not be suffering from any kind of a systemic disease, and it would be a bilateral presentation. And along with that, all of the other investigations carried out, for instance, the baseline investigations would be normal for these individuals. Talking about the variants of these corneal dystrophies, we have a range of these dystrophies affecting the different layers of the cornea. It can be the epithelium that is involved in most of the cases, or either it can be the stromal layer, and then finally we have the Descemet layer that is involved in some of the cases. Starting off, we have the epithelial and the subepithelial variety over here. The most of the cases, most oftenly that we come across, they have no inheritance detailing. The genetic locus that is most probably involved in these cases is 5q31 that is mutated for these patients. The gene that is responsible is TGF-beta1, and this gene is mostly responsible for this kind of a genetic mutation, and finally having the congenital abnormality that is affecting the epithelium, or either it can be the subepithelial structures that are involved for these patients. So what are the symptoms that are quite peculiar to the epithelial basement membrane dystrophy? Because when you have to diagnose the patients, you must be well versed with the kind of presentation they are going to come up with. The erosions with pain is one of the common presentation. Again, it's very tricky to diagnose these patients. Either they are suffering from some sort of an infiltrative disorder, an inflammatory condition, or either it's an erosion that is due to the fact of the genetic mutation of the epithelial cells themselves. So usually identifying the key pathology, that is the underlying pathology in these patients, is very important. These patients would usually come up with pain, and when you would examine these patients, they'd be suffering from corneal erosions. Then finally, obviously, a blurred vision, as cornea is the major factor or the major transparent structure that is present interiorly to the eye. And that is responsible for transferring the rays to the lens and obviously identifying the image at the back on the retina. So if it's a blurred cornea or if it's a hazied cornea, that is basically going to blur the vision for the individual. Then obviously excessive lacrimation and signs of irritation would be noted down in these individuals, as well as irregular astigmatism. As the corneal surface is eroded, there would be these features of astigmatism that are noted down for these individuals. So these are the key features, the key clinical symptoms in these patients of epithelial basement membrane dystrophies. The signs that you'd be looking for as a clinician, you should know what are the peculiar features that you would pick up in these patients, or the maps or the mapping material. As you can even appreciate over here in this picture, you can appreciate that there is this haziness, but it's not a uniform haziness noted down over the entire cornea. It's basically the map-like structures, as you can observe over here, just like a globe. It's resembling much more like a globe. There are these gray, thick, hazy epithelial structures. And then we have an appearance which is known as the Cogan's appearance. When this is the appearance, this is the kind of appearance, it would give off a dot-like appearance to the haziness. Non-staining, putty gray opacities would be noted down in these kind of patients. Then we have another variant, which is basically a fingerprint lines. Usually they are the paracentral, or they are affecting the periphery of the cornea. The bleb patterns are best seen by the retroillumination or by the indirect illumination. And then we have a poor adhesion of the basal epithelial cells that can also be seen in these patients and noted down in these patients. So upon complete clinical examination, and upon examining the patient on direct or indirect illumination, making the patient or observing the patient under a slit lamp is very important over here, because that would really diagnose the kind or the pattern of the haziness noted down for this particular patient, and that is basically different for different patients. Then when we talk about another variant, which is basically an epithelial recurrent erosion dystrophy. So it's not just the epithelium that is involved, but these cases are usually in a recurrent phase, and they usually present to the outpatient departments after a certain period of time, and they have multiple visits when you note down the history for these patients. The characteristic of this kind of a dystrophy would be an inheritance, which is of an autosomal dominant pattern, and the genetic locus and the gene involved is usually unknown for these patients. They appear typically at 4 to 6 years of age, and the attacks decline in frequency and intensity as the age advances. So basically, there is some sort of a genetic mutation in these patients that is making the kid more prone to the development of corneal erosions. What is the gene involved? That is not known. It's an unknown etiological factor. And still, you would give off the supportive treatment for these patients. You would give off all the protective factors for these patients, and educate the patient regarding the condition, and obviously also educate the patient regarding the prognostic factors of the kid as well. You would educate the patient and the parents as well that the attacks are going to subside as the age advances for the kid. The signs and symptoms for the epithelial recurrent erosion dystrophy are the corneal erosions noted down for these kids, as well as we'd be looking for the subepithelial haze blebs on examination. The central subepithelial opacities are noted down, and the redness, photophobia is usually complained of by the child himself. Epiphora and ocular pain. Epiphora is usually the excessive lacrimation that is termed as epiphora clinically, and ocular pain is also complained of by these children. The treatment for the epithelial recurrent erosion dystrophy if it doesn't subside and if it continues to recur for this individual, you would advise for corneal grafts at the mean age of 45 years. And if it is just hindering the vision of the individual, then it is very important to perform this kind of a corneal graft. Moving on, we have another variants. For instance, we have the subepithelial mucinous corneal dystrophies that we can observe. We have now moved down to the stromal layer, sort of a stromal layer involving the columnar epithelium, or either it can even involve the stroma. It's a mucinous variety. That means that it is going to have some sort of excretions as well in these patients. And obviously, it is going to relate to corneal dystrophies in these patients. So this would be a typical picture of subepithelial mucinous corneal dystrophy. You can observe and appreciate the haziness over here. These are the dot-like haziness that is observed in the cornea of this patient. And this would be sometimes coupled up with the mucinous discharge in these patients as well. The peculiar features for this kind of a subepithelial mucinous corneal dystrophies are we have an inheritance pattern that is noted down for these patients. It's an autosomal dominant inheritance pattern noted down. The genetic locus that is involved is unknown for this kind of a disease. The onset and course is progressive loss of vision that is noted down and that is complained of. It's going to start off with the blurring of vision, and finally it can result in the loss of vision if it is left untreated. The signs would be the bilateral opacities and the haziness observed in the cornea, and the symptoms would be the episodes of recurrent erosions. The cornea is more prone to the development of erosions in these individuals as well. It's a uniform factor, as you would observe while we are going through the different types and the different classifications of corneal dystrophies. You're going to note down that all of these are going to have the similar episodes of signs and symptomatologies. How do you get to know what kind of a dystrophy this particular patient is suffering from is the peculiar features of the corneal haziness and the accompanying signs. For instance, in the subepithelial variety, you're going to note down that it is coupled up with the secretion of mucinous discharge that is peculiar for just the patients of subepithelial erosions and is not noted down for patients of the epithelial erosions. So these are the peculiar features that you're going to note down in the patients. Then we have the Meesmann corneal dystrophy, and this is the peculiar picture for the Meesmann corneal dystrophy. It is an autosomal dominant dystrophy, and usually it's also known as the Stockel-Holt dystrophy. This is another name that is commonly used clinically by the patients. The dotted pattern is very important, and you would observe that this is the bleb-like pattern that is noted down in these patients, and the corneal haziness is quite scattered uniformly involving the whole of the cornea. Stockel-Holt variant, as I've already mentioned, and we have the inheritance that is involving an autosomal dominant variety over here. It's again the genetic loci involved is the 12q13 for these patients, that is the KRT3, and another gene that can also be involved for these patients is the 17q12 variety. It's the KRT12 variety. These are the genetic mutations that can occur in these patients and result in the Meesmann corneal dystrophy. The genes involved are the keratin. Production of keratin is affected, KRT3 and KRT12 is involved. The signs that would be noted down are the multiple epithelial vesicles as well as the pattern. Again, the dotted pattern is the basic variant, and you could remember that picture that I've already shown you, the clinical picture. The dotted pattern is the major presentation. That would be basically the epithelial vesicles that is giving off that dotted pattern when you're observing the patient under a slit lamp. The symptoms are glare and light sensitivity noted, and the patient would also complain of a mild visual reduction initially. And then finally, the corneal scarring takes place, and that is coupled up with the blurred vision. Moreover, we have the punctiform epithelial erosions also as one of the complications that occurs in the Meesmann corneal dystrophies. Another variant that we usually come across is the Lesch's epithelial corneal dystrophy. The features involved over here are the typical appearance of the inheritance, that is usually an X chromosomal dominant appearance noted down. We have a direct illumination that shows localized gray opacities in the cornea. Indirect illumination shows the multiple crowded clear cysts. As you observe over here, this is the cystic lesions that can be observed, this grayish cystic lesions that are observed in the cornea. This is the exact clinical picture that you would see for these patients. This is known as the Lesch's epithelial corneal dystrophy, the appearance of the cysts at the epithelial level. And then we can also observe the clear cysts also at the level of the epithelium of cornea. The patient would usually complain of blurring of vision if the pupillary zone is involved. And obviously, if the transparency of the cornea is affected, it is going to affect the vision of the individual. Another variant involved is the gelatinous drop-like corneal dystrophy in these patients. So this is how the picture is for this kind of a corneal dystrophy. The usual presentation again for these kind of patients is the first and the second decade of life. The child or the parents of the child would usually come up to you with this kind of an appearance in the cornea. This is usually quite an alarming situation for the parents as well. How did it develop and what really caused this kind of an haziness and the opacities at the level of the cornea? What were the causes of this haziness in the cornea? The education of the patient over here is very important. Educating the parents is very important because sometimes they would, even after you tell them that it's a congenital abnormality, they would still like to investigate the child for any kind of infections that he or she may be suffering from. So if you have excluded ophthalmia and unitarum in these individuals, you can be quite sure that this child is suffering from some sort of a congenital abnormality on the other hand. The peculiar characteristics over here would be, in the first decade of life, the conduction is progressive for these children. The gene locus involved for these children is 1p32. This is the kind of genetic location. The gene is TACSTD2. And then we have the subepithelial lesions, the stromal opacifications that are noted down, and this would be the peculiar picture or the most commonest presentation as a child would present to you in the outpatient departments. Neovascularization is also noted down at the level of corneal epithelium. The symptoms would usually consist of the photophobia, and obviously the irritation and the redness would be coupled up along with this kind of the photophobic condition. There would be a decrease in the vision noted down, and the tearing. So excessive lacrimation or epiphora is one of the kind of presentation for this kind of a patient. Then we move on to the Bowman layer dystrophies. We have the commonest presentation of this involvement of the Bowman layer. The Bowman layer is involved for this kind of dystrophies. The genetic locus or the gene involved is 5q31 and the gene is TGFBI1. Inheritance is autosomal dominant pattern. The signs included are the coarse geographic-like opacities, as you can even appreciate for this patient. The onset and course is usually in the childhood, and there would be a progressive loss of vision even noted down for these individuals as well. Another variant, which is known as the Reese-Buckler's corneal dystrophy, this is another name for the stromal variety or the Bowman's layer variety. There would be an impaired vision, as we have already seen with the other patients and with the other abnormalities or the corneal dystrophies, as well as there would be an ocular discomfort noted down by the patient. Usually, the pain is in the first decade of life. So this is the commonest presentation, the commonest clinical picture for these kind of Bowman layer dystrophies. Moving on, we have another variant, which is the Thiel-Behnke corneal dystrophies. The characteristic features over here are the onset and course for this kind of a dystrophy is it usually occurs in childhood, and progression is the loss of the vision. The genetic locus or the gene involved over here is the 5q31 and the TGFB1. And then we have the inheritance, which is in the autosomal dominant pattern for these individuals as well. The sign and symptoms, again, that are involving this kind of a corneal dystrophy are the irregular or the reticular opacities noted down to stromal layers, and corneal peripheries are involved. It is coupled up with the gradual visual impairment and ocular discomfort and pain for these individuals as well. Moving on, another variant or which can also be discussed as one of the variants is the Grayson-Wilbrandt corneal dystrophy. Just summarizing the key features, we have the inheritance pattern, which is autosomal dominant. The signs are the patterns of opacification noted down, as well as the refractile bodies in the corneal stroma. The symptoms are decreased visual acuity, discomfort, and eye pain, which is a common feature for all of the corneal dystrophies. The stromal corneal dystrophies, which are also known as the lattice corneal dystrophies, are just having the clinical picture like this, and they're presenting or they are having the corneal dystrophies involving the epithelium as well as the stromal layer of the cornea. The clinical features would include the genetic locus is 5q31 gene is TGFBI1, and then we have an autosomal dominant pattern, which is quite progressive, and obviously that is linked up to the blurring of vision. Ocular discomfort and pain, which is basically requiring a penetrating keratoplasty for these patients. So it's very important that how can you improve the quality of life for these patients once you have diagnosed them to be suffering from any kind of corneal dystrophy. What are the steps that can be taken for improving the quality of life? The classical lattice corneal dystrophy and the signs that are coupling up with this kind of a dystrophy are the branching spider-like amyloid deposits. And along with that, we have irregular lattice work in corneal stroma. Then we have to note down the number of lattice lines that are differing in both of the eyes because it is a bilateral condition. So it's again very important to note down the differences of the lattice work degeneration in both of the eyes. It is sometimes quite difficult to diagnose this kind of a patient, and it is usually the most peculiar features for this kind of the dystrophy is the lattice work and the sparing of the periphery. That is quite an important feature for this kind of a lattice work dystrophy. Apart from the classical lattice work dystrophy, we have the gel-saline type of corneal dystrophy. It is also noted down, or it is also termed as the type 1 lattice corneal dystrophy. Usually, this kind of a dystrophy is associated with amyloidosis. So, systemic amyloidosis, if it is diagnosed, or if the patient is a diagnosed case, or if he or she is not a diagnosed case, you're going to run down the tests. The peculiar test for amyloidosis, and once diagnosed with amyloidosis, this patient can be coupled up with this lattice work, degenerative or dystrophic features in the cornea. Then this condition would be termed as the gel-saline type 1 opacities in the patient's eyes. The characteristic features are the genetic locus involved over here in this gel-saline kind of opacities is the 9q34 and the gene is the gel-saline GSN. The inheritance is again an autosomal dominant variety. It is a slowly progressive variety. It usually presents in the 3rd or the 4th decade of life. So the kind of presentation in these corneal dystrophies is again very peculiar. The signs as a clinician that you would note down are the lattice lines in the corneal stroma. Coupled up with that are the more peripheral lattice lines, as well as the corneal sensitivity is reduced and absent in these patients. Dry eye syndromes, which are known as the xerophthalmias, are also one of the key features along with these kind of dystrophies. Usually, the visual acuity would appear to be normal for these patients. The presentation would be in the 3rd or the 4th decade of life. So this would be the complete clinical picture for a patient with lattice corneal dystrophies, gel-saline type. Then we have the granular dystrophy type 1. The presentation again is a granular form of the corneal opacities that you would note down for these patients. When we're discussing the type 1 granular corneal dystrophies, the peculiar genetic locus or the gene involved for this kind of a dystrophy is 5q31 and TGFB1. The inheritance is autosomal dominant, and the signs involved are the milky granular hyaline deposits in the anterior stroma. Usually, these are coupled up with the vortex pattern of the brownish granules also noted down. So this kind of the granulations are brownish in discoloration as well as there would be the milky appearance. So sometimes any of these two pictures can appear in the patient. Either there is a brownish discoloration that is given to the granules, or either it can be a milky white haziness noted down for these patients. The symptomatologies over here would be the glare. That is very important. So it's kind of a very important sign when you'd ask the patient, he'd complain of a slight photophobia or the glaring phenomena when subjected to, or when he's looking to, or upon photoillumination, he would complain of this glaring that he's observing or suffering from. Watering from eyes, epiphora, excessive lacrimation is basically a part of the irritative processes that are taking place. Then obviously the visual acuity is also going to be decreased due to the excessive granulations, whether they are grayish, brownish, or the milky white appearances observed. And then the photophobia is also observed along, and it's one and the same thing when we say it's a glare. This is basically an initial sign, and if it is advancing, then the patient would be complaining of excessive photophobia, excessive lacrimation on photoillumination. Patient would also complain of ocular discomfort and pain as well. The type 2 corneal dystrophies would appear quite peculiar. Again, there would be the appearance of granulations, and that can involve even the periphery or the axial forms of the cornea. The peculiar features would be a genetic locus 5q31 that is quite similar, the TGFB1 autosomal dominant variety. Usually the signs that would be included in the type 2 variety are the subtle superficial stromal tiny whitish dots. As you can observe, these are the tiny whitish dots that are observed, and they're not only involving the epithelium, they're also going up to the level of the stroma. And these are quite subtle. They can involve the axial as well as the peripheral pattern. One of the variants for the type 2 variety is the ring or the stellate, that is the star-shaped snowflake appearance of the stromal opacities. Then there can be the lattice lines deep in the cornea, or either it can be a presentation which is quite superficial, translucent, as well as flat or breadcrumbed opacities. Breadcrumb opacities would basically relate to very fine granular opacities at the corneal stromal layer, and again, that is going to affect the vision of the individual as well. Then the patient can also suffer from the macular corneal dystrophies. Again, the cornea, the corneal granulations, the corneal haziness is going to be coupled up with the macular dystrophies. The vision of the individual is going to be excessively damaged as well. The characteristic features of the macular corneal dystrophies are the genetic locus, which is 16q22. The gene involved over here in the macular dystrophies is quite distinct. It is CHT6, and we have the autosomal recessive inheritance over here. Up till now, we have been studying the autosomal dominant varieties. This is quite an exception, and you can basically peculiarly remember the fact that the macular corneal dystrophies are of an autosomal recessive inheritance over here. They have the white lesions. The symptoms are going to be of pain and photophobia. And then we have the diffuse stromal haze that is usually coupled up with the macules noted down in the corneal stroma. Usually when we have the skin lesions, they are sometimes defined as papules, and if it is a raised lesion, if it is a raised irritation, that is sometimes known as a macular region. So this is basically the terminology that is used, that is the same terminology used for the skin lesions over here. Rather than the diffuse opacities, or rather than the granular opacities, all of the granules coalesce together and they form a raised lesion, which is known as a macular lesion, involving the corneal epithelium or even the stromal layer. Now, another characteristic corneal dystrophies are the Schneider corneal dystrophies, and we should know how to distinguish between the congenital stromal corneal dystrophies, and on the other hand, we have the Schneider corneal dystrophies over here. The genetic locus and the gene involved in both of these cases is basically for the Schneider corneal dystrophies, we have 1p36, gene is UBIA, and the genetic locus is 12q21.33, and the gene involved over here for the stromal congenital dystrophies is the DCN. The inheritance pattern is autosomal dominant for both of these disorders. The signs and symptoms include the ring-shaped central corneal stromal opacities, which is coupled up with the glare. And finally, if it is a complicated case, the patient would be suffering from photophobia, excessive lacrimation, and ocular pain as well. For the stromal corneal dystrophies, we have a diffuse cloudiness, a bilateral corneal clouding whitish stromal opacities noted down for this kind of a variety. So it's again very important to keep all of the clinical features as well as the pattern of inheritance, and along with that, the genetic loci and the final gene that is involved for all of these corneal dystrophies that we have been studying. Moving on, we have a fleck corneal dystrophy. Again, there is a granular pattern, but the granulations are quite excessive for this fleck kind of variety. As you can observe over here, there are excessive granulations involving the epithelium, involving the stromal layer of the cornea. The gene involved is the 2q35, and the genetic locus involved is the 2q35, and final gene affected is the PIP5K3. We have the inheritance to be autosomal dominant pattern. The flat gray-white dandruff-like opacities, it's an excessive granulations or the flake-like opacities that would be excessive in number, and obviously the amount of granulations is going to affect the vision of the individual in quite a manner. The posterior amorphous corneal dystrophies are congenital in nature. There's an autosomal dominant pattern noted down. There's a diffuse gray-white sheet-like patterns noted down for the posterior amorphous corneal dystrophies as well. And they appear largely asymptomatic for the individuals. Then we have the central cloudy dystrophies of Francois. So usually these are the axial kind of varieties that you would note down. The cloudiness is going to be axial, but still it is going to affect the vision of the individual. It's not going to affect the blurring, but the excessive cloudiness is going to result in the complete loss of vision or astigmatism in the individuals. The pre-Descemet's corneal dystrophies are also quite importantly known. We should know that sometimes these dystrophies can involve the epithelium, the stroma, and even the pre-Descemet's layer, which is the toughest membrane of the corneal histology. It can be even involved in the dystrophic structures. The pattern again is autosomal dominant for all of these, but still the features can be quite different when you're going to look for, or when you're going to have when you're going to detail for the prognostic factors. You should know what level of the corneal histology is affected in a particular patient. Then we have the Fuchs endothelial corneal dystrophies, and it's basically involving the stroma, the Descemet's membrane, as well as the internal limiting membrane in these individuals. The signs and symptoms would be quite peculiar, involving the blurring of the vision, as well as the photophobia, excessive lacrimation, and signs of irritation would be coupled up in this kind of a clinical picture over here. The stages of the cornea guttata can be noted down when you're looking at the features under the slit lamp. You're going to look for the stromal opacities. Either they can be of the granular type, and if they're involving the peripheries and the limbus, that is the corneal guttata's appearance. The stage of the endothelial decompensation can also be seen in this. And then is the stage of the bullous keratopathy. If there is the corneal perforations, that would basically lead towards the complication of bullous keratopathy. And then finally, the stage of cicatrization, if there is a healing process that is going on, that would lead to the stage of scarring in this kind of Fuchs endothelial corneal dystrophies. As the name is indicating, it's the endothelium that is also involved. There can be a complete through and through perforation for these patients. So that is basically going to start up the healing process and the final cicatrization process for these individuals as well. The treatment over here would consist of the hypertonic saline that is prescribed, and along with that we have the warm air blown into the eyes. Penetrating keratopathy is sometimes prescribed if the scarring is quite sufficient. We're going to perform the keratoplasty as well. Just to protect the cornea, we can aid the patient to bandage with the soft contact lenses. And the IOP lowering drugs, that is sometimes the atropine, the cycloplegic drugs, are quite important to have a comfortable intraocular pressure for these patients. The posterior polymorphous corneal dystrophies are one of the variety that is basically relating to the involvement of the anterior chamber as well. There is going to be an excessive granulation, excessive opacification noted down for these polymorphous corneal dystrophies. The signs and symptoms involved for this kind of a dystrophy are the deep corneal lesions of various shapes, railroad track appearance lesions, the gray tissue at the level of the Descemet's membrane. So this would be the peculiar features you would note down in this kind of the posterior polymorphous corneal dystrophies. Then we have the congenital hereditary endothelial dystrophy 1, involving the endothelium. Once we're done with the epithelium, we have another variants and another genes involved for involving the endothelium of the cornea. The signs and symptoms included for this kind of a variety are the endothelial changes, which would be a moon crater-like appearance in the endothelium. There would be an ulceration that is basically giving off this moon crater kind of appearance. Then the corneal clouding and an increase in the intraocular pressure is also noted down when you're going to have a diffuse haze to a ground glass appearance of the haziness and intraocular pressure is raised. The thickening of the cornea 2 to 3 times of the normal thickness, as well as the subepithelial band keratopathy, may be occasionally seen for these patients of endothelial dystrophy type 1. The type 2 varieties are also quite common, and they have their distinctive patterns that we're going to observe in these patients. The signs and symptoms involved and the genetic loci would be the 20p13, that is a teloremic transmission. And then the gene involved over here is the SLC4A11. Then we have the pattern, which is the autosomal recessive kind of patterns noted down. The features would be more severe than the type 1 variety, and then the patient might also be suffering from nystagmus. The X-linked endothelial corneal dystrophies and the signs and symptoms involved over here are the nystagmus that may be associated with it. Talking about or elaborating nystagmus could be the to and fro motions of the pupillary region are basically noted down as the nystagmus. They can be associated with the nerve lesions as well as the opacities. The corneal opacities can basically cause this kind of a nystagmus in this patient. Corneal clouding since birth is one of the important features. Subepithelial band keratopathy is noted down in these patients, and the moon crater-like endothelial changes, which can be seen on the slit lamp, is very important. That is basically the formation of the ulcerations at the endothelial level. So basically, in this lecture over here, we summarize the major corneal dystrophies. Summarizing the mainstay over here is the distinguishing factor between the degenerative processes as well as the corneal dystrophies. If the patient has not been suffering from any kind of trauma or infiltrative processes or infectious states, then you can consider the patient to be suffering from corneal dystrophies. Again, having a look at the cornea and to know the basic presentations of these dystrophies is very important. The pattern of distribution is again very important, and how are they transmitted genetically is focused upon in this lecture. So that is the end of this lecture. Thank you for watching sqadia.com.